patient who comes to his doctor complaining of some sort of pain in his chest or discomfort or distress, particularly if it occurs during exercise, probably has angina pectoris. Such a patient really merits a very thorough clinical study because it's most important to recognize the fact that this person probably has a significantly narrowed portion in one of his coronary arteries and that he is seriously threatened with a major heart attack that could constitute a total disaster. When such a patient is referred to us here at UCLA, he comes into the cardiology group where he is seen by one of the cardiologists for his preliminary studies. This would include a very detailed history taking. First point of interest, of course, is to ascertain whether or not the complaint really is that of angina. When you say to him, what does it feel like? He'll say, first of all, I really can't explain it. And then as you watch him, his hand will begin to creep up toward the middle of his chest, and he'll start to make a fist and squeeze, and then you really know you've got the right answer. Because even without the words, that gesture is highly specific for the person who is really experiencing anginal distress. Usually it's associated with exercise. And because of this, we often like to study the patient while he's actually having such an episode and simulating the exercise that ordinarily would give it to him. Having satisfied oneself that the resting electrocardiogram is normal, that the history does indeed suggest true angina, and that the physical examination has excluded other forms of heart disease that could mimic angina, we would then wish to proceed to exercise testing.
Let's consider the worst one, the worst discomfort of that nature that you've had as a 4+ discomfort.
4+.
And the mildest, the very beginning of it, a little trace of it, as a 1+. And what we're going to try and do on the treadmill here is work you up till you get to a 3+, which is going to be a fairly well-developed sense of discomfort, but not as the worst one that you've ever had.
There are really two things that one wants to find out by treadmill testing. The first is to confirm the diagnosis absolutely by demonstrating the characteristic electrocardiographic changes that occur when the heart becomes ischemic. This is manifest by depression of the ST segment in most instances, although elevation of the ST segment may occur in a few. This would confirm the presence of the ischemia, but we want to know more than that, really. We really want to know how bad it is. And in order to do this, one has to perform an exercise tolerance test. In other words, we want to see how far the patient can go before he's actually stopped by the symptoms which he experiences in his daily life.
You let me know when we reach that stage.
The way we do this is by increasing the workload of the treadmill stepwise every 3 minutes until the patient is brought to a halt by the symptoms that he experiences.
Associated with
pain, but it's just squeezing.
Squeezing, I see. And you're a little short of breath?
Looking for, you know, like second wind you keep.
Okay.
Can't get enough air.
You feel as though you ought to stop now?
No, all right. Just keep on. It's creeping up there a little bit. It's.
So you've reached the 3+ stage yet?
Yeah, it's about that.
Okay. Well, this is the stage we decided we were going to stop at, so we'll just stop now.
Okay.
The 1-year anniversary of his open heart operation, wherein a double vein bypass graft was performed, connecting the root of his aorta to the distal portion of his anterior descending and circumflex coronary arteries. Now, he's walking here at about 3 miles an hour on this treadmill and is about ready to go to the 4-mile-an-hour stage. Willie, are you having anything resembling the type of distress that you were having before the surgery?
Absolutely not.
Are you having any trouble in your ordinary daily life experience?
No, sir. I work every single day. I enjoy my work. Get up in the morning, exercise, go to work, come home and eat, go to sleep, live.
We've seen 2 patients today, and we've shown how one of them required surgery while the other did not. The one who did not was in a non-precarious state, but he remains symptomatic, and therefore he requires continued treatment, just as the man who had the surgery. Now, what does this treatment consist of? First of all, both of these gentlemen have tendencies to elevated blood cholesterols, and one of them has a high blood triglyceride level. This means that both of them have to observe very strictly controlled diets, the avoidance of weight gain, and the attempt to lower these cholesterol and triglyceride levels in the blood. In addition to that, they both have symptoms under certain conditions. The man we saw first has substernal oppression as well as breathlessness under certain conditions of exertion and exercise. When he has this, he requires nitroglycerin tablets. He carries these with him at all times and uses it promptly when he experiences discomfort. This begins to have an action in about 30 seconds and usually takes the discomfort away in less than a minute. Now, when he's going on his daily walk, he knows that he needs more prolonged protection because he's going to be walking for 45 minutes to an hour. When he does that, the agent that he takes is isosorbide dinitrate, the one that you chew up. This enables him to get through the entire walk without having any distress. The onset of its action is very rapid, almost as fast as regular nitroglycerin. In fact, in our tests here in the laboratory, we've been able to show that the onset time of this chewed up form is anywhere from 30 seconds to 2 minutes, which is just about the same as regular nitroglycerin. But we also know and have shown by some experiments that we've conducted here that this agent has a prolonged period of action, sometimes as long as 3 hours, but more often somewhere between 1.5 and 2 hours. This is the room in which a special group of angina patients who have the unique property of not having their anginal pain during exercise, but who have it during periods of repose or even while they're deeply asleep, arousing them from sleep with pain that's entirely characteristic of the angina that is described by people who have it with effort, but under totally different circumstances. These people can do exercise without having any discomfort or distress, and therefore they are not detectable with exercise testing. The only way they can really be found and the diagnosis proven is by monitoring one of the anginal episodes at a time when they're actually having it. Since they're not likely to have an electrocardiograph taken during deep sleep, it becomes a difficult problem to make the diagnosis. Sometimes we bring them into the coronary care unit and monitor them continuously, and in that way are able to find these episodes when they occur. But there's one approach that is very useful, recently developed, perhaps 6 or 7 years old now, called the Holter tape recorder EKG monitor. The patient carries it around on a pack over his shoulder. It's entirely portable. The electrocardiographic leads here can be attached to his chest, the wire coming out through the shirt, and the entire pack being carried around during the day-to-day activities, either awake or asleep. This tape recorder is carried in this pack and is mounted in the package here in such a way that the tape is threaded, and when the switch is turned on, the tape deck begins to roll the tape through at a very slow rate of speed. Now this allows this amount of tape to go for a full 12 hours, and then when it's played back on the scanner, which we see here, the tape is played through at 60 times normal speed. Thus, every minute is equal to 1 hour. In that way, one, by watching the display on the oscilloscope, can monitor a full 12-hour period of time in just 12 minutes. Now, the technician is going to turn on the machine and show you one of the tapes that we recorded from a lady who has been having severe and intense attacks every night, somewhere between 2 and 4 in the morning. Would you turn it on, Lisa, and let's see the pattern. You can see the normal-looking electrocardiographic pattern being displayed on the face of the scope, and in a few moments you'll see a little preliminary blip as the T-wave increases its amplitude. There it was. Now this is a preliminary to the attack that is soon to come. As we watch the display, we hear the background noise that is related to the heart rate, the pitch being regulated according to the rapidity of the heartbeat. There is the abnormality which was displayed. She suddenly disconnected the plug and turned it upside down to reverse the polarity. That was her signal to us that she was experiencing an anginal pain at that very moment. device, and we see the deviation of the ST. Again, she reverses the polarity and shows us the abnormality of the electrocardiogram. Now, the signal from the tape, after finding it on the oscilloscope, can then be transferred over to the recording device and written out as a real electrocardiogram. And here we see the period when she's sound asleep and recording a normal electrocardiographic pattern. Within a few moments, however, we see that there's a deviation of the pattern with elevation of the ST segment and the T wave. And as this progresses, she goes on to a very marked elevation of the ST segments with a highly abnormal display indicating an injury current. And then even later she wakes up and disconnects the plug, reverses the polarity in such a way that it turns the EKG upside down, using this as the signal that she's experiencing the heart pain. And as we go along, we see some even more striking abnormalities indicated by occasional skip beats representing a second-degree heart block, obviously due to ischemia of the AV node. The Holter tape recorder is another mechanical device that has helped enormously in the diagnosis of cardiovascular disease. As most medical devices, it is costly, not only for the equipment that's required to carry it out, but for the technical help that's necessary to process the tapes. As with most of our diagnostic methods, the more sophisticated we become, the higher goes the price. And a person who has a thorough workup for his coronary disease, and perhaps, if it's serious enough, ends up with an operation, may find himself beset with bills totaling thousands of dollars before he's finished. This is distressing to us in the profession, and we'd like to be able to find ways of doing it much less expensively for the public. In my opinion, the best way that we can hope to meet this problem would really be to institute preventive measures before the disease gets a foothold. This is really a problem that must begin early in life, in the teenage years perhaps, when dietary habits are becoming established. Furthermore, patterns of physical activity, conditioning, and the avoidance of smoking are extremely important components of this phase of life, when control of these risk factors offers a real hope of being able to reduce the mortality and the incidence of this dreadful, widespread disease.